Thank you. Thank you, Dr. Morcos, Danny, Sebastian, Amir. I thought maybe I'd talk about dealing with the vascular, especially arterial problems during the skull-base surgery. Not cerebrovascular surgery, but skull-base tumor surgery. So I have no disclosures. It's hard to predict the true vascular encasement. Is it truly encasing the artery or wrapping around about preserving the arachnoid plane? And I cannot appreciate with any imaging extent of the encasement or engulfing. Sometimes you see vascular narrowing or irregularity, that's a warning sign. But some of these cases you explore, you don't see any problem. You get through without any difficulty. But some of them can be really warning signs. And then I noticed in few cases, I start looking at the perfusion studies in MRI or CT angiograms. If they especially have a perfusion deficit, that can be a problem. And most important thing is the anterior choroidal and the posterior communicating and their branches involvement in this, especially anterior and anterolateral skull-base meningioma. It can be quite challenging. So are the lenticular striae for the M1. My tips for this, and always study radiology and get maximum information about the vasculature in or around the skull-base tumors. Check the potential collaterals, cross-filling. If necessary, do the balloon test occlusion, and always exercise the bypass options, how to repair in case of trouble. And always, I'm on the pessimistic side. Maybe I always think about the worst case scenario, how I can get into trouble and how I can get out of it. And then if you encounter the trouble, don't be insistent if you are not dealing correctly. Just stop, ask opinion, or do something else, or move to other dissection plane. Or just back off, just stop it. You are not fighting against the tumor, you are fighting for the patient, okay? So in conclusion, we should be versatile in dealing with complex vascular issues in skull-base surgeries. We need to go to the lab early in our training and continue going to the lab, and always obtain proximal and distal control, and don't underestimate surgeries being simple or easy. The vascularized, debulk, dissect, respect the arachnoid plane. Transarachnoidal approach, as put by Jacques is the safest thing, and you have to have a multiple backup plans. Don't repeat the same complications. Change your routine if you are having many complications. Be creative when you encounter the unpredicted obstacles. Never give up. Be determined. Don't be minimalist because you cannot do it. Skeletonize vessels and move them away. Don't think you don't have any option. Always there are options. And be aware of the old literature, history, and what your mentors did in the past when they encountered this kind of problems. I always finish with the Jacques sayings, go to the lab, anatomy, correct localization, correct surgical approach, and when you encounter the problem, rectify the problem. Thank you again. Thank you, Dr. Morcos, for organizing this, and the organizers, and all the participants, and the distinguished lecturers.
Thank you, Mustafa. Very, again, beautiful example how to deal with vessels that are stuck to tumors. It shows you why you really need to be both a microvascular surgeon and a skull-base surgeon to really bridge both disciplines. Again, lots of questions we will tackle at the end.